Yes. Like my mother recently went into surgery. So she was on SGLT2 inhibitor and everything. It was continued. So my question is like, if you stop the drug, like patient is on GP3 or GP4 whatsoever, and if you just prescribe stop the SUs or stop the SGLT2 2 days before because the patient is at his home. So what happens to his sugar? And then on the day of surgery, he comes, it's 250 or 300.
So that this is what we discussed. So what I would do, for example, let's say your mother is planned for surgery. I Yeah. So let's say I'll generally call such a patient 2 to 3 days prior to surgery. I will, first of all, reduce the dose of, or generally half the dose of your SU, remove the SGLT2, and put the patient on a basal insulin, right? Maybe add a DPP4 or something if required, right? And then monitor the patient. Eventually, in a couple of days, I'll remove the SU altogether and keep titrating the basal accordingly. And by the time, so remember, the first, for example, your mother is going to go undergo surgery on Monday. She's going to take a basal insulin on Sunday night, right? So that's going, and assuming that we have done a good job the last couple of days, then in that scenario, you already got the fasting under control. So when the patient goes to there in the morning, they're going to check the blood sugar. It's going to be 130. They are not going.
Most of the patient will deny insulin, as you know, in the
But
practice.
see, this is the point. So that
Practical.
yeah. So that issues are going to remain, right? Those are systemic issues.
So
But
in our OPDs, patient doesn't usually go for insulin.
but to be honest, this is an area where patient generally takes the insulin, right? So you tell them कि भाई surgery है उसके, there are patients who कैटरैक्ट सर्जरी करवाना है वो नहीं करेंगे जब तक पेशेंट का ब्लड शुगर कंट्रोल नहीं होगा, तो इंसुलिन क्या कुछ भी जीएलपी भी लेंगे, whatever they'll take whatever you give them, right? So right.
Patient
Unpredictability.
response or pharmacodynamics, we can something like that we can write, because as you told, hypoglycemia risk is there with any drug.
Yes.
Particularly, we are going to use insulin, which has a similar hypoglycemia risk like
Correct. So I would say
sulfonylurea.
unpredictability, especially with long-acting
Yeah,
sulfonylureas.
so we should something like that we
Yes.
should add instead of writing just a hypoglycemia risk.
Fair enough. Fair enough. Great. So, Dr. Sagar, anything you want to add? Yeah, okay. Right. So, yeah, any other point before we close this? Great. So, I think we had a good consensus meeting, and we can end it here. And what the next step would be that we are going to take the controversial areas. They are going to put it in some sort of a form, right? And they'll share that where you'll have to kind of just say, what is your consensus on the areas of controversies. I think we agreed to 70 to 80% of the things. So I think those we can be just put in the consensus without any disagreements. But the areas which require a little bit of consensus, they'll be sharing we'll be asking for your views. You can just put that up, and then that will be the majority view is what will be the part of the guideline, and then that can be then taken over and published, right? So thank you, Dr. Sagar, and thank you all for being part of the